So today I'm going to talk about a very interesting case which I encountered during my training, and it is a mesodiverticular band in meckel's diverticulum, which resulted into a small bowel obstruction. So to begin with, let us see what do we know about this case. Now, this is meckel's diverticulum, as we all might know, is one of the most common congenital anomalies. Now, this is a true diverticulum, and by mean, we mean that it is made up of all the three layers of small bowel, and the blood supply is derived from the superior mesenteric artery. Now, meckel's diverticulum has a rule of 2, which means it is 2% present in the population, located 2 feet from the ileocecal junction, and is 2 inches long. Now, this is what we all know so far. Also, most of the cases are asymptomatic. Complications arising from meckel's diverticulum are usually intestinal obstruction or bleeding, abdominal pain undiagnosed, and in acute cases can also lead to perforation and very, very rarely can cause malignancy. It is most common in the male population and in elderly, where we find the complications. And the length is more than 2 centimeters when we have the complications. This occurs due to the failure of closing of the middle intestinal tract, which occurs during the 5th or the 6th weeks of embryogenesis. So what is a mesodiverticular band? So if you can see the image, this is the loop of the small bowel, basically terminal ileum, and this outpouching is the meckel's diverticulum. Now, this is the vitelline artery or the branch from the superior mesenteric artery. So what happens? A loop of the bowel goes inside, as in between the artery and the meckel's diverticulum, causing obstruction. So coming back to our case. So I have this 72-year-old lady presented with 24 hours history of worsening abdominal pain, distension, and vomiting. Now, this gentleman had a background of asthma, hypertension, hyperparathyroidism, had an end-stage past, and a Whipple's resection 6 years ago for cholangiocarcinoma, which he recovered from. In the blood, he was found to be in AKI, as we can see with the eGFR of 32, and mildly raised WBC and CRP. On examination, we found he has got abdominal distension and tenderness or palpation. So, from the history of abdominal pain, distension, vomiting, and clinical examination of distension and tenderness, we had a clinical diagnosis of intestinal obstruction. So this is the X-ray. As we all can see, distended small bowel loops with air fluid levels, as the horizontal marks we can see. So multiple air fluids level. So this is an acute intestinal obstruction. Now, to plan for the surgery to find out where the obstruction was, because he had a past history of Whipple's resection, we did a CT scan. And now this is a CT scan image, which shows, as we can see, the distant small bowel loops and then the collapsed bowel loops as well. So they had a transition point in the right iliac fossa, as we can see in here, but we couldn't find an obvious cause, as in no mechanical obstruction cause could be found. So the patient obviously went for an emergency laparotomy. In the emergency laparotomy, we found band adhesions compressing the ileum, and on relieving, we found the mesodiverticular band in the meckel's diverticulum, which was the cause of the bowel obstruction. Hence, we have to resect 10 centimeters of the unhealthy bowel, which contained the meckel's diverticulum, and then we had a side-to-side anastomosis. This is the photo, if you can see. The tiny outpouching is the meckel diverticulum. Overlying this was the band adhesions. And that is why it was all unhealthy. So let us quickly discuss about this case. The term meckel diverticulum is eponymous from the German anatomist Mr. Johann Friedrich Meckel the Younger, and this was described first in 1809. Most common complication could be obstruction, and there are various causes for that. Most common causes being the diverticulum being short, and they got thickened with either inflammation or has ectopic tissue inside, or has a tumor which acts as a lead point, leading to the obstruction in forms of intussusception. There could be diverticulitis arising from the diverticulum and can cause band adhesions on that. Acid secretions by ectopic mucosa can also cause stenosis because, as we know, the diverticulum does cause ileal tissues and gastric tissues as well. Then there could be occlusions by fecolids, enterolids, or bezoars. Then, very rarely, we even can find a hernia, inguinal hernia, which is called the Little's hernia. So all of these can cause obstruction. Now, they are mostly diagnosed incidentally because this is a very rare cause, and hence we do not think about them as a first cause. Mostly are asymptomatic, as I already discussed. But we tend to do further investigations for this when we have unexplained causes of GI bleed, perforation, inflammation, or obstruction. In most common cases, as I mentioned, are asymptomatic. Now, there are two types. The first type, when we have only one attachment to the intestine or no attachment at all. The free diverticulum forms a volvulus on itself as in twisting, causing obstruction. And adhesions commonly occur between the two arms of the twist, causing obstruction. In the second type, there is a diverticulum which is attached to the abdominal one or to the other intestinal viscus. Now, mesodiverticular bands are associated with high mortality. Hence, this is really important. Moving forward, there is a study by Cullen et al., which looks after the outcomes of diverticulectomy or resection of the bowel relating to complications. They have found the operative mortality is 2%, morbidity is 12%, and long-term post-operative complications is 7%. But if we do an incidental diverticulectomy, which means there is no symptom, in that case, we see the percentages are almost similar, as in mortality is 1%, morbidity is lower, 2%, and risk of post-long-term complications are 2%. Thus, so why is this case important? Firstly, diagnosis of meckel diverticulum as a cause of small bowel obstruction is often not made until we do the operation, because it is barely seen in the scans and we barely think about it clinically as well. CT scan, although very accurate in identifying obstruction, it has very poor sensitivity and specificity in detecting the cause of this. Hence, this is a rare case of small bowel obstruction due to complications from mesodiverticulum and should be taken into consideration of small bowel obstruction. Asymptomatic patients, whether all cases should be resected or not, are still question of debate. However, we have seen for symptomatic patients, treatment must include resection of the segment containing the pathology. So I would like to thank my consultant, Ms. Jane McClemens, who is a consultant surgeon in the Royal Victoria Hospital. And these are the references based upon which I wrote my case report. So, thank you so much. Anyone has any questions at all?